So this is the final part of my talk about diuresis renography. In the first part of this talk I gave an introduction and explained what PUJ, pelvi-ureteric junction obstruction, is and talked about some of the possible investigations. In part 2 I covered the principles and talked about kidney transit times and how these are affected by administration of furosemide as a diuretic. Part 3 covered the practicalities. I discussed the protocol for diuresis renography and explained how to interpret the results and gave some examples. Now in Part 4 I'm going to compare diuresis renography with one of the alternatives, which is deconvolution of the renogram to calculate mean transit time. I'm going to discuss which method to use, talk about the timing of furosemide and the dose of furosemide to administer. So, as I said in the previous parts of this talk, diuresis renography is a technique which compares the whole kidney transit at both low and high flow rates. So you only need to draw one region of interest for each kidney, but it must include all of the kidney, including the renal pelvis. And then you compare the shape of the renogram curves before and after furosemide. The advantages of that technique are that it's very simple to use. It only needs a visual analysis and it's very quick. There are no special tools needed to analyse the renogram. It's also reliable because it can be used in almost all patients. The disadvantages are the possible discomfort to the patient from a full bladder after they've had the diuretic administered. It only gives a qualitative result rather than a numerical result. It says whether it's obstructed or non-obstructed or possibly an intermediate result. It's no use if the kidneys have got poor function, and it's not so good if there's a very grossly dilated system, because the pelvis may be so dilated that even the dose of furosemide that we use may not flush things out. Deconvolution renography, on the other hand, looks at the parenchymal transit times just at the normal flow rate, so you don't need to give furosemide. You use the whole kidney region of interest as well as a separate parenchymal region, which includes just the parenchyma and excludes all of the renal pelvis. The advantages are that you don't need to give furosemide, and it gives a quantitative result. It gives a number for the transit time. That may well be a benefit for research where you want to correlate that number with something else. But in routine clinical practice, if you give a doctor a number, the first thing they ask is, well, what's the normal range? And they soon turn that number into a normal or abnormal result. So the quantitation may be not so important for routine clinical use. The disadvantages are that it's a much more complex analysis, which unfortunately is very sensitive to errors. It needs more accurate region of interest, particularly for the parenchymal region, and it doesn't work in all patients because of all these little difficulties. It also requires a higher administered activity in order to get enough counts, and it also is no use if very poor function, because there won't be enough counts in the renogram. I discuss all of those disadvantages in the other talk that I've given about deconvolution analysis. So the question is, should we use diuresis or deconvolution to diagnose PUJ obstruction? Well, neither measure pressure directly. Pressure is what affects the damage to the kidney if it's a high pressure system, and neither of these techniques measure pressure. They all look at different aspects of the same problem to infer pressure indirectly. Now, the results usually agree between patients, whichever technique you use, but patients being what they are, there are all sorts of variation. So they may not agree in all patients. There are always the odd patients who will give different results by the different techniques. So when asked which I recommend, I say, well, you can use either. In Manchester, we favour diuresis renography because it's a simple technique. We developed it in Manchester, and clearly we're influenced to use that as the main technique. There are other centres who may well prefer to use deconvolution to calculate mean transit time. So I'm not saying that either method is better than the other. I leave it to you to judge from what I've said. However, my only proviso is don't try to use both at the same time. The problem there is that frusemide changes the urine flow rate, and that invalidates deconvolution. In my talk on deconvolution, I explained that one of the principles under which deconvolution relies is that the flow rate must be constant throughout the study. And clearly when we give frusemide, the urine flow rate increases, and so that is not the case, and therefore after frusemide you cannot safely apply deconvolution. You'll get a silly answer. Now if you use F0, where we administer frusemide right at the beginning of the renogram, clearly the flow rate will be changing throughout the renogram, so deconvolution won't work with F0. If you use F+20, where frusemide is given 20 minutes after the start of the renogram, then the first 20 minutes will be okay, but you must stop the calculation of transit time after you've given frusemide. So you can't use the data beyond 20 minutes, which means that the estimate of the transit time may be underestimated. If you give F-15, where we give frusemide 15 minutes before the start of the renogram, clearly the flow rate will be changing after you've given frusemide, but some people say, well, the flow rate will have reached a constant, a plateau, 15 minutes after the frusemide, so it's therefore safe to use deconvolution after that. But I'm afraid, although that happens in some patients, they don't all reach a plateau after 15 minutes. So I think it's dangerous to rely on a constant flow rate in F-15 renography. So here is some data that's used to support that. This is a graph that comes from the ISKCORN report on transit time measurements from the renogram published in 2008. Now, ISKCORN is the International Scientific Committee on Radionuclides in Nephrurology, and they use this graph to show what happens after you give frusemide, and they show the flow rate here increasing rapidly about 3 minutes after frusemide, coming up to about 25 mils a minute, and then by 15 minutes it's plateaued and reached a constant value. And they use that to say that if you are using F-15, it's okay to apply deconvolution, because by the time you start the renogram 15 minutes after frusemide, the urinary flow rate has reached a constant, and therefore deconvolution is still valid. Now, this particular graph is been taken from an earlier publication. It's based on work by Steve Brown, Steve Upstill and Paddy O'Reilly, which they published in the British Journal of Urology in 1992. And I know that work was started by Steve Upstill when he was working in our department, so I've gone back to his MD thesis, which was published in 1989, and looked at the data there. He has data there from 17 patients, which was a subset of those from the BJU article, but it shows the same effect. The flow rate increases and then is fairly constant at about 25 mils a minute after that. However, that's the average of 17 patients, and of course Steve there has got the individual patient measurements, which I've plotted on this graph here, and you can see from that that some of them go up between 15 and 30 minutes, and some of them indeed come down between 15 and 30 minutes. So yes, the average is constant between 15 and 30 minutes, but in any individual patient I don't think you can rely on the fact that the flow rate is going to be constant after 15 minutes. So I am very wary of trying to apply deconvolution at any time after frusemide, and even with F-15 I don't think in any individual patient you can rely on the fact that the flow rate is constant, and therefore I don't like to apply deconvolution at any time after frusemide is administered. Now, although you can use either diuresis renography or deconvolution renography to assess PUJ obstruction, there is another compromise approach. You could use a visual assessment of parenchymal transit from the images alone. For example, if you look at the 1-minute summed images or a cine of the raw data, you can assess whether activity leaves the parenchyma in good time and how long it takes to reach the collecting system. In fact, in 2009, Schlotzman and colleagues published an article advocating something they called tissue tracer transit, TTT. They defined a delayed TTT as the patients in which the pelvis has not filled by 8 minutes, or where the shape of the kidney remains stable between 2 and 10 minutes, indicating that the pelvis isn't filling, or the activity in the parenchyma increases with time, or the clearance from the parenchyma to pelvis is slower than the other kidney on the assumption that the other kidney is normal. A timely TTT with patients who exhibited none of the above, but they had some intermediate TTTs with equivocal results. However, they found that TTT was a good predictor of the outcome of surgery, which is indeed what you want to see in these patients. One benefit of this method is that it can be combined with diuresis. Here's an example from our own patients. You can see here in the right kidney the curve goes up and up and up, and even after furosemide it doesn't empty, indicating that that is an obstructed system. But if you look at the images, you can clearly see the parenchyma early on. The parenchyma continues to concentrate, and even towards the end of the study the pelvis is not filling. So it's a delayed TTT. The activity doesn't move from the parenchyma into the pelvis. And indeed the same pattern is also true in the left kidney. And this technique doesn't prohibit the use of furosemide because we're not doing deconvolution. We don't need to do the calculation of transit time numerically. It doesn't rely on there being a constant flow rate. So you can combine this visual technique along with diuresis renography. Here's another example of a diuresis renogram from our Manchester patients. Here is a renogram for the whole kidney, and you can see that the curve goes up and up and up, and it doesn't empty until furosemide is given, and then it comes down very promptly and empties very rapidly after furosemide, indicating that this is a not obstructed system. Now, normally in Manchester we don't go on to perform deconvolution, but for a series of patients we did compare with deconvolution. So here is the result of deconvolution on this patient. Now, deconvolution produces a curve called the impulse response function, which I've explained in more detail in my separate talk on deconvolution renography. But it's sufficient to say that it produces a curve here showing emptying from the whole kidney, and it shows that in this case the whole kidney it takes a long time to empty. In fact, by 20 minutes it hadn't come right down to 0, but if we calculate the average kidney transit time, it comes out to be 10 minutes. In fact, we can say it's more than 10 minutes because this function hasn't come to 0 by that time. But we had to stop the calculation at 20 minutes because giving furosemide at 20 minutes means that deconvolution is not valid in this patient after 20 minutes, and so we had to truncate the calculation here. So we know that the transit time is at least 10 minutes, probably greater. That's enough to say that this is a long transit time through the whole kidney, but what really matters is what the parenchymal transit time is. So if we drew a region of interest over the parenchyma alone, we get this curve for the parenchymal transit time, showing that that's quite normal at 2.7 minutes. So by the parenchymal transit time method, this is a non-obstructed system, which agrees with the result of the diuresis renography. In fact, however, if you look at the curve from the parenchyma, you can see that that in fact does empty before the furosemide. So in fact, you can get a result simply by drawing the parenchymal curve and observing that that empties. You don't necessarily need to go on to do the deconvolution. So in fact there's three ways of looking at this data. You either look at the response to furosemide for the whole kidney curve, or you look at the impulse response function for the whole kidney and the parenchyma, or you can just look at the parenchymal curve for the renogram before furosemide. And in this case all of those indicate that this is not obstructed. Here's another example of a patient that is obstructed. We can see the whole kidney curve doesn't empty even after furosemide, so this is clearly an obstructed system. And if we go on to do deconvolution, we see that the impulse response function for the whole kidney also doesn't come down to 0 by 20 minutes, and the whole kidney transit time is more than 8 minutes, because we had to once again stop the calculation at 20 minutes when frusemide was given. But in this case, the parenchymal transit time is also long, so this is what would be called an obstructed system for the parenchymal transit time, because the parenchymal transit time is also long. But once again, if we just look at the raw curve from the parenchyma, we can see that that doesn't empty before frusemide. So we have another way of looking at that, saying that the whole kidney curve failed to empty after frusemide. The whole kidney transit time is long and the parenchymal transit time is long, but not only that, the parenchyma failed to empty, so we can look at that as another way of looking at the whether the system is obstructed or not. But in Manchester, my routine is just to use the Diuresis Renography with frusemide. However, the series of patients where we went on to compare with deconvolution showed that the patient had similar results by mean transit time. Now, people often ask about the timing of frusemide. What is the best time to give frusemide? And there are really three possibilities. F-15, where you give frusemide 15 minutes before the start of the renogram, is useful because it produces the maximum diuresis at the time of the renogram, so it's useful for follow-up of equivocal cases to push the system to its limits. The snag is that you don't know what happens at normal flow, so on its own it may not identify patients who only obstruct at high flow, because you don't see what happens at normal flow in these only have F-15. The other problem is you can't calculate the mean transit time with deconvolution, as I've already explained, because I don't believe that you can guarantee the flow rate is constant even 15 minutes after frusemide. F0, where you give frusemide at the same time as the MAG3 or DTPA for the renogram, is convenient in children because you only need to get one injection and one needle in. The disadvantage is that you don't know what happens at normal flow, and you definitely can't calculate mean transit time with deconvolution because the flow rate is definitely not constant. So F0 has a limited use apart from in children. F+20 or something similar like F+15, where you give frusemide partway through the renogram, is useful because you get to see the normal behaviour before you administer frusemide and the behaviour at high flow rate after frusemide. However, it only allows you to calculate mean transit time up to the time at which frusemide is administered, and you must ignore the calculation after that. But you need to be careful that the renogram continues for 15 minutes after the frusemide, otherwise you may miss Holmes's sign. So in Manchester we tend to set up renograms for 40 minutes as standard. The preference in Manchester has been very much for F+20 for a first renogram, possibly with an F-15 for follow-up cases. The other thing is how much frusemide to administer. The standard dose for adults is 0.5 milligram per kilogram, and for children it's 1 milligram per kilogram up to 40 milligrams. However, you have to remember that frusemide reaches its site of action by tubular secretion. It has to be secreted into the renal tubules in order to have its effect. So a poorly functioning kidney, which has less tubular secretion, may not get sufficient frusemide to the site of action to produce sufficient diuresis. So if you've got poorly functioning kidneys, don't expect a normal response, or maybe consider increasing the dose of frusemide in order to compensate for the reduced function. You can check whether you've achieved adequate diuresis by asking the patient to empty the bladder before the renogram starts, and then at the end of the renogram empty the bladder again and measure the volume produced. Now that will give you the flow rate by dividing the volume by the time, but remember that's the flow rate from both kidneys. So if you've got one obstructed kidney and one normal kidney, it doesn't necessarily guarantee that you've achieved the adequate diuresis in the obstructed kidney, only in the two kidneys together on average. There's a question of how much furosemide to give in children. If we look at the guidelines from the Society of Nuclear Medicine and the European Association of Nuclear Medicine, for adults they say 0.5 milligram per kilogram body weight up to a maximum of 40 milligrams. So we get this graph of dose against patient weight increasing linearly up to a maximum of 40 milligrams for an 80 kilogram patient. The same organisations for children say it's 1 milligram per kilogram body weight up to 40 milligrams, and the British Nuclear Medicine Society also refer to those guidelines. So you might say, well, why is it more for children? Well, the justification there is that for infants, where the kidneys are not so mature, you need a high dose of furosemide to achieve the same amount of diuresis. So for infants, it's justified to give 1 milligram per kilogram body weight, and that's the basis of that. However, this guidance seems to go on to older children, so it seems to me that that gives a higher dose of furosemide than is necessary for most children above 1 year. Now, if you go back to some of the previous guidelines from the European Association of Nuclear Medicine, they said 1 milligram per kilogram for infants, which is justified by the less maturity. For above 1 year, they said 0.5 milligram per kilogram, which gives the green line here, but they said a maximum of 20 milligrams, which clearly didn't give sufficient dose for children over 40 kilograms, which is why I think they changed it from the green line, the previous recommendation, to the blue line, which is the current one, although that does seem rather high for most children. Interestingly, ISKCORN, the International Scientific Committee on Radionuclides in Nephrology, also say 1 milligram per kilogram for infants, but above 1 year they drop to 0.5 milligram per kilogram, and going up to 40 milligrams for adults, which is the red line, and that seems to me to be the most sensible dosing. But you choose whichever guidelines you want to follow for that, I think. So back in 1993, I wrote a little parody on Hamlet's soliloquy expressing the choice between these two techniques. To diurese or not to diurese, that is the question. Whether it is better in the renogram to suffer the mild discomfort of distended bladder caused by administration of the diuretic furosemide, or use a higher dose of pharmaceutical and by deconvolving calculate mean transit time. Whether to follow the simple northern route of O'Reilly's diuretic renogram or the southern sophistication of Britain's parenchymal transit time. In hydronephrosis, to diurese, to deconvolve, to diagnose perchance obstruction. Aye, there's the rub. So in summary, for diuresis renography, patients must be adequately hydrated. You perform a standard renogram, and if one or both kidneys fail to empty spontaneously, you give furosemide at 20 minutes. You can continue the acquisition for a further 15 minutes, and if it's a low pressure system, that is a hypertonic system, then the diuresis will flush the activity out of a large volume renal pelvis. If it's a high pressure obstructed system, then the diuresis will be unable to overcome the obstruction, and if you get an equivocal result, it's helpful to repeat with furosemide 15 minutes before the start. If you suspect an intermittent obstruction, then repeating with F-50 may show whether it only obstructs at high flow rates. But don't rely on the mean transit time if you're giving furosemide, because furosemide changes the flow rate and that invalidates deconvolution. So treat any transit times calculated with conjunction with a diuresis renogram with a pinch of salt. So if you found this talk interesting, you may be interested in more of my renogram talks. I have one on models of the renogram, which includes 7 different models showing the shape of the renogram. I have one about how to process a renogram, explaining where to draw the regions of interest, how to achieve correct background subtraction, and how to quantify relative function and elimination from the renogram. I've got another on how to display a renogram, which includes a description of how to quantify absolute uptake and how to allow for different kidney depths in the renogram. I have another on the renogram explaining the Rutland-Patlak plot, giving details about the Rutland method of background subtraction in the renogram, and another which I've referred to in this talk explaining details of how to perform deconvolution to calculate mean transit time from the renogram, and all of those are available on my YouTube channel.